Okay, here we go. Pretty crazy, right? I use disposable keratomes for these cases because I prefer larger paracentesis wounds in cases with CDK and corneal degeneration, especially in older patients. This patient was on the high side of 80. Because I found that in these patients, they're at far greater risk of Descemet's detachment. Now, the corneal wound was 2.4. The capsular rhexis here looks large because the clear cornea is itself so small, confined as it is by the Pannus and severe arcus. I would note that the microscope illumination is turned down by necessity because glare from the central climactic droplet keratopathy, the CDK, and the peripheral Pannus/arcus would otherwise be blinding. Sorry about the off-center recording. It does recenter at 3 minutes, so just bear with me. Like I said, I don't usually keep these recordings. I just snagged this one as an afterthought. So a comment about the technique. The technique is central sculpting using about 80% torsional phaco, and then followed by vertical back chopping. Now, a lot more information would be required about this technique if somebody wants to, if somebody really wants to get into it. But that is the technique. Central sculpting to create space so that I can work deep in the eye away from the cornea. And then I have found vertical back chopping to be the most effective technique that I can use on these cataracts. But it's not just a simple vertical back chopping. There are elements of that have to be modified and adjusted to make the procedure safe. As you can well imagine, there's a rather narrow safety profile for these cases. The harder the cataract, the more narrow the safety profile. So we're just going to let this run. I do not believe in editing videos. I don't like to edit the phaco portion. It's so easy to make a difficult cataract surgery look good if all you present are the cherry-picked good moments. So this is the full phaco. As I said here, we're recentering at 3 minutes. The technique is to enter with the second instrument, which is my own instrument. It's a modification of a Connor wand. It has a double curved design with a paddle shape at the tip instead of an olive tip. So enter between the anterior capsule and the cataract, sweep around, and then either do a horizontal or a vertical back chop, depending upon what is required. I try to phaco over the remaining cataract to protect against posterior capsule rupture. Viscoelastic refill you see here at 3 minutes and 50 seconds. Basically, about every 3 minutes into the phaco, I will do a viscoelastic refill. Now, you will notice at the beginning of the case, which was 1 minute, and then here again at 4 minutes, you will notice that I do not enter the eye until the continuous irrigation is turned off. I have had a couple of total Descemet's detachments over the years, and they always happen when the irrigation port is at the cut edge of Descemet's. Usually entering the eye, irrigation port at the cut edge of Descemet's, the irrigation gets under that cut edge and just dissects Descemet's off in the blink of an eye. So this is a protective measure taken in these patients. So I do not enter the eye under irrigation. I enter under viscoelastic and then turn the continuous irrigation on once inside the eye. In addition, you will note that the irrigation sleeve is rotated 90 degrees. This orients the superior port of the irrigation sleeve onto the bulge of the Kelman tip, effectively occluding it, so that irrigation only comes out of the inferior port. I enter the eye tip sideways and do the case with the one active irrigation port oriented sideways or down to avoid irrigating the cornea so as to reduce endothelial trauma from irrigation in these prolonged cases. You have to be especially careful of surge in these cases because you are only irrigating half the solution that you would if both irrigation ports were open. But in my experience, it's more important to protect the cornea. And as I think you will see here, surge is at a minimum. So once again, I'm just going to let this run. I have not edited it, but because I want you to see the full procedure. I'm using the second instrument now to basically pull forward the very, not totally, but somewhat sclerosed epinucleus, and bring that forward to the phaco tip. If it comes, great, but I don't push it. And then I just go ahead and do a little reach around there and pull it forward. By the way, it looks kind of scary. It always feels kind of scary putting a second instrument behind the epinucleus, especially in a case like this where you can't really see well enough. You're always, throughout the case, you're sort of wondering, when's it going to drop? When's it going to drop? When am I going to see vitreous? But with good fluidics and noticing that the anterior chamber is stable from the beginning of the case, I think that you can do this with relative confidence. Also, reaching around with that second curve of the second instrument oriented downwards, so as to not present the tip directly to the posterior capsule, but rather present the neck of that second curve. Reduces the risk of posterior capsule rupture. I think I have had posterior capsule rupture from the second instrument using it this way. Well, no, I know I have, but it's very rare. It's much more rare than a person might imagine, just because the curve, that second curve on the tip, is really quite forgiving. Okay, now we reorient the IOL at this point in the case. I don't leave it like this with that, edge showing. Do reorient the IOL, place air, and that's about it.